When reviewing a spirometry report, always begin with quality. Results can only be trusted if the test was performed properly. The first step is to check acceptability and then confirm repeatability, and only afterwards move on to interpreting the results. Start with the curves. On the volume time curve, you should see a steep rise that flattens into a clear plateau. On the flow volume curve, look for a smooth, unhesitating start, a sharp rise to peak, and followed by a smooth, continuous downward slope. If the curves look uneven, broken, or cut short, the test may not be valid. Think of acceptability as 3 simple questions. Does it have a smooth and unhesitating start? A smooth downward curve without artifact? And no evidence of early termination? If the answer is no to any of these, the blow is not acceptable and should be repeated. Next, check repeatability. At least 3 acceptable maneuvers are needed. After having obtained at least 3 acceptable curves, the 2 best values for forced expiratory volume in the first second, FEV₁, and forced vital capacity, FVC, should be within 150 milliliters of each other in adults, or 100 milliliters in young children. Meeting this threshold confirms that the patient gave consistent effort. Once you know that the test is valid, interpretation becomes much more straightforward. In simple terms, you're asking 2 questions. How much forced air came out in the first second, and how much came out in total? These are your forced expiratory volume in the first second, FEV₁, and forced vital capacity, FVC, which provide the FEV₁ to FVC ratio. In most spirometry reports, the FEV₁ to FVC ratio will be shown as a number and compared against reference values for someone of the same age, sex, and height, calculated by the spirometer defining a predicted normal and a lower limit of normal LLN for the FEV₁ to FVC ratio. Airflow obstruction is defined when the post-bronchodilator FEV₁/FVC ratio falls below the lower limit of normal. The LLN is often expressed as a Z-score, which shows how far the result is from the average of a healthy population. A Z-score less than -1.64 confirms obstruction. For example, a report might show an FEV₁/FVC ratio of 46.7, with a predicted LLN of 73.7 and a Z-score of -5.61. Because 46.7 is below the LLN of 73.7, and the Z-score of -5.61 is less than -1.64, this confirms obstruction. A fixed FEV₁ to FVC ratio cutoff of 70% is sometimes used pragmatically for COPD screening. However, interpreting spirometry through the LLN and Z-score is preferable to using a fixed FEV₁ to FVC ratio cutoff. The LLN and Z-score account for age, sex, and height, and avoids both over- and under-diagnosis at the extremes of age. For example, a 30-year-old woman with an FEV₁ to FVC ratio of 0.74 may be abnormal if it lies below her LLN, whereas an 80-year-old man with an FEV₁ to FVC ratio of 0.69 could still be normal if above his LLN. Once the FEV₁ to FVC ratio has been assessed, the next step is to consider the forced vital capacity, FVC. Similar to interpreting the FEV₁ to FVC ratio, FVC is considered normal if it is at or above the lower limit of normal. If the FVC falls below the lower limit of normal, it is considered reduced. A low FEV₁ to FVC ratio with a normal FVC indicates an obstructive pattern. A low ratio with a low FVC suggests a mixed obstructive and restrictive pattern. A normal ratio with a low FVC points towards restriction. although this must always be confirmed with lung volume measurements. Finally, when both the ratio and the FVC are normal, the result is considered normal spirometry. By following this structured sequence, you can identify patterns with confidence, while ensuring that the quality checks have been properly applied. Now, time to solve a short quiz to reinforce your learning. A set of selected IPCRG resources will be available for you at the end of this breath.